Good day, everyone, and thank you for joining us for the second in our series of Learning and Action Network webinars, Merit-Based Incentive Program Improvement Activities. My name is Jane McGraw. I'm a Program Manager with Stratus Health, the Minnesota organization that is part of Lake Superior Quality Innovation Network, or the Ellis Quinn. Our partners in Ellis Quinn are Medistar of Wisconsin and MPRO of Michigan. The Ellis Quinn is a part of the Centers for Medicare and Medicaid Services Quality Improvement Organization program. Today's presentation is being recorded and all participants will be muted. We encourage you to submit questions or comments through the chat at the bottom right-hand part of the page. Please be sure that the send to is all participants when you send a note in chat so that we receive that. We may not be able to address all questions today, but we'll use your comments and questions to help guide and inform future events. If you have specific questions you need assistance with after the presentation, please reach out to your state Ellis Quinn QIO contact following today's presentation. You will find their names and email addresses at the end of the presentation in the slide deck. The PowerPoint for today's presentation there's a link in the chat section where you can download the PowerPoint for today's presentation. Today's presenter is Candy Hansen. Candy is a program manager for Stratus Health. She has been the program lead for the Physician Quality Reporting System and the Value-Based Modifier Program, and is now the lead for Minnesota's Quality Payment Program. She has 20-plus years of experience working in long-term post-acute care settings in public health. She is a graduate of the Leadership in Health Information Technology for Health Professionals program from the University of Minnesota. She is also a graduate of the Practice Facilitation Certificate program from the University of Buffalo. I will now turn it over to Candy.
Thanks, Jane. Welcome, everybody. So Jane already kind of reviewed who the Lake Superior Quality Innovation Network is, but again, we are the three states of Michigan, Minnesota, and Wisconsin working together to help everyone through this quality payment program journey that we're all on. So for today, I'm going to provide a brief context of the improvement activities category within the quality payment program. I want to talk to you and clarify the scoring of the improvement activities category. I want you to learn about the activities and the activity subcategories within the improvement activities category, and help you gain knowledge about the key resources and tools for improvement activities and the quality payment program. Before we go into the details of the Improvement Activities category of the Merit-Based Incentive Program, or MIPS, we wanted to remind you that CMS has declared 2017 to be a transition year for MIPS, meaning that you have the flexibility to choose how you will participate in 2017. The first category is called the test pace, in which you can submit some data after January 1st, 2017 for the performance year, which is calendar year 2017. And if you do that, you will receive either a neutral payment adjustment, no payment adjustment, or you may be eligible for a very small payment adjustment. Something to keep in mind for the test pace is whichever category you would choose to participate in for 2017, you would have to pay attention to the specifications or the frequency of which you would have to report. And I'll go into more details of that in just a minute. But if, for example, you're picking a quality measure that is a once-a-year measure, then you would choose that quality measure for once a year. For improvement activities, for example, the minimum that you would need to do to be successful in the test pace would be to pick one activity for a minimum of 90 days. And as I said, I'll go into some more details about that in just a minute. If you've been doing well or fairly well in your reporting and attestation for meaningful use and for PQRS, you may choose to choose a partial year, in which case you would choose a 90-day period after 2017, and you would report on the three categories for the 90 days. And then if Your third option, if you weren't in an alternative payment model, would be to report everything for a full year for a participant starting after January 1st, 2017. Another option that you might think about is that you might want to just go ahead and collect your data and run your reports for the full year and then just analyze your data. If you don't feel like it's really as good as you want it to be for 2017 and producing the results you want to, you may choose a 90-day period out of that full year that you have been reporting. So just wanted to remind you of the pick your pace options for 2017. I'm going to do a quick overview of the Quality Payment Program because we believe it's important to hear the details again and again as we get used to the new environment that we're all operating in. So the Quality Payment Program repeals the Sustainable Growth Rate Formula, which is known as the Doc Fix. This is why at this time we don't believe when the administration is talking about repealing the Affordable Care Act, it's not a part of the Affordable Care Act, and so at this point we don't believe that it's going to go away. It streamlines multiple quality reporting programs into the new Merit-Based Incentive Program, or MIPS, and as you know, it provides incentive payments for participation in both MIPS and an advanced alternative payment model. In this program, there are two tracks. There is the Merit-Based Incentive Payment System, or MIPS, and the Advanced Alternative Payment Model track. So again, the CMS legacy programs of PQRS, or the Physician Quality Reporting Program, the Value-Based Modifier Program, and Medicare's Electronic Health Records EHR Incentive Program, or Meaningful Use, are all streamlined into one program called the Merit-Based Incentive Payment System, or MIPS. This slide is a visual provided in a slightly different format to help us understand the two tracks of the Quality Payment Program. As you can see, the two tracks of the Quality Payment Program are the Alternative Payment Program track, which has in it a subset of advanced APMs who will not have to participate in MIPS. There are alternative payment model clinicians, though, who will not qualify as an advanced APM and will be MIPS-eligible clinicians in the alternative payment model. We'll provide more information on alternative payment models as we get later into this year. In the MIPS track, there are 4 categories whose weights are listed for 2017. Those weights will change every year after 2017. It is important to keep in mind that meaningful use for Medicare-eligible providers, who are now referred to as eligible clinicians, has been replaced by the Advancing Care Information category in MIPS. Meaningful use for Medicaid EPs, as well as for Medicare and Medicaid for eligible hospitals and critical access hospitals, will remain as meaningful use. The implication for this is that it is possible that you will have to attest to both meaningful use and advancing care information, depending on how you've attested in the past. CMS is expecting in this transition year that there will only be 5 to 8% of clinicians who will qualify as advanced APMs, and that most clinicians, 92 to 95%, will actually be MIPS-eligible clinicians in 2017. CMS is also expecting that by offering this 2017 transition year and the Pick Your Pace options, that almost all clinicians will have the opportunity to be successful reporters and attesters in 2017. So, can we go back one slide? Thank you. All right, so now we're going to go into more details about the Improvement Activities category. The Improvement Activities category is a new category. It is designed to use a patient-centered approach to better, smarter healthcare by improving clinical practice. Not all of the activities are evidence-based, but they were chosen because they have a proven association with better health outcomes. CMS put out an RFI request for information to identify activities and specific criteria that would help clinics be the most successful in the improvement activities category. The design incentive of these activities is actually to drive movement towards the alternative payment models and ultimately advance movement towards the APMs. If you're a part of an APM, such as a Medicare Shared Savings Program, you have a specific agreement with CMS, and CMS dictates by the type of ACO that you are or the type of alternative payment model that you are of which activities you will be able to choose from in 2017. For all other MIPS-eligible clinicians, there are over 90 activities to choose from. The activities are weighted either as medium or high, and the medium activities are worth 10 points each, and high-weighted activities are worth 20 points each. To receive full credit towards the weighted 15% of the MIPS score for improvement activities, you will need to score 40 points. The way you get credit for improvement activities is to attest that you are actually performing that activity for the duration of the time that the activity is listed as being required. This attestation will occur somewhere on the CMS website in 2018. We are not sure yet how that will occur, but we are told after 2018 or as we get closer to the end of the year, that we'll learn how that attestation will occur. Most participants will attest that you completed 4 improvement activities or 2 high or 4 medium for a minimum of 90 days. There are some exceptions. CMS is recognizing that groups with 15 participants or fewer, or if you're in a rural or health professional shortage area, that you will have completed up to 2 activities. So you're getting credit for being a smaller entity. If you are a patient-centered medical home, which CMS has deemed Minnesota healthcare homes to be a PCMH deemed-like status, you actually automatically receive all credit or full credit, the full 40 points, just by virtue of having been a healthcare home in Minnesota for 2017. And I recognize that other states might not have healthcare home certified models in our region, so I was just referring to Minnesota, actually, in that statement. Groups in APMs qualifying for special scoring under MIPS, such as Shared Savings Program Track 1 or Oncology Care Models, you also will receive points based on the requirements based on participating in your APM. So as I mentioned on the slide before, if you're in an ACO or you're in an alternative payment model, you're going to want to check with your model to see which activities and how much credit you actually already received by virtue of being in that model. So these are the 9 subcategories that each of the activities fall under. And again, it's about improving clinical practice. So some examples are shared decision-making, patient safety, coordinating care, increasing access. We actually think that the improvement activities category will be one of the easiest categories to be successful at. If you use your CERT to carry out specific activities, you'll have an opportunity to earn a 10% bonus in the Advancing Care Information category. Out of the 90-plus activities, there are actually 18 activities that will qualify for that 10% bonus. And as you can see, the URL at the bottom of this slide will take you to the Advancing Care Information fact sheet because that's where you'll earn that 10% bonus for your improvement activities using a CERT. And so you'll click on that URL and then scroll down to pages 9 through 19 to find out which activities actually qualify for that bonus. This is just one example of one activity that is a CERT-related activity that could qualify you for a 10% bonus in the Advancing Care Information category. going across the column, the first column lists the activity subcategory. The second column is a brief description of the activity. In the middle, you'll see the total description of the activity and all of the details about how you'll be successful at attesting to that activity. And then the next column lists whether the activity is rated either as medium or high. The last category lists the related advancing care information measures that that category could be related to. So in this example, using your EHR to assign risk status would qualify you for the 10% bonus.
Sandy, would you like to take any questions during the program, or do you want to hold your questions to respond to until the end?
Sure, we can do questions now. I think we're in a good enough place.
We've got one question from a viewer who says, is scoring different for small groups submitting only 2 improvement activities, or do they still need 40 points to get the full 15%?
Oh, great question. Thanks for the question. So you already get credit, so you get double points. I believe this is the category. I believe this is the category that you get double points for because you're a small, less than 15. So you would actually automatically, by choosing those two medium activities or 1 high activity, you would automatically go to the 40 points. So I hope that makes sense.
And then another question was the one that you were just talking about for the 18 activities for that bonus.
Yep.
How many of those activities do you have to achieve? Do you know that?
This is Reed with Stratus Health sitting along with Candy here. So like Candy was explaining, you pick from that list of 18, and then you're only going to have to do 2 high or 4 medium if you're one of the standard participants, or if you are one of those in health professional shortage area or under 15, then like Candy explained, then you would do 1 high and 2 medium, or some combination thereof to achieve the 40 points.
So in order to get the bonus, though, then you would have to do those cert activities for all of the activities you chose. Is that what you're saying, Reed?
So you would actually only have to, I'm sorry, misunderstood the question just a little bit.
Yep, no
but
worries.
You would only have to do one of those activities to get the 10% bonus for the advancing care information category.
Yep, and that's what I remembered as well, but I thank you for clarifying that. So hopefully that answered your question. So just one of those activities have to be done using CERT. But in most cases, you're going to be doing all of your activities, you know, using your CERT or many of your activities. So.
And once again, too, if you're already participating in these, you know, the previous meaningful use program, et cetera, you very likely will, by virtue of doing a lot of things in an electronic CERT environment, discover that you are either doing the requirements of those or maybe just have to tweak your workflow just a little bit to accomplish that. So read through that list of 18, and I think you'll be pleasantly surprised.
Mm-hmm. And even all of the activities, actually. I mean,
overall,
they're generally things that many clinics have been doing for a long time already, and now you'll just get credit for them in a way that puts you in a positive place in the transition year for Quality Payment Program. So you can attest to the improvement activity in the improvement activities category in the following ways, which is basically all of the ways that you have been attesting and reporting except for claims. There's no way for claims to accommodate understanding that you're doing an improvement activity. Through a qualified registry out of your EHR, using a qualified clinical data registry, and if you are reporting via CMS web interface, for those who report as a group of 25 or more clinicians using that CMS web interface. I will tell you, it's probably worth your while to look into the qualified clinical data registry option for attesting and reporting. CMS, in the final rule, is really pushing that particular strategy. And so what that means for the future, we're not 100% sure yet, but we do know that, for example, in the improvement activities categories, there's several activities that are activities that you can qualify for by using that qualified clinical data registry.
Andy, we just had one more follow-up question that was about the point system. So I read, this is the question says, I read that you can do a combo of both medium and high. What is the ratio to get the 40 points?
So depending on the setting that you're in, and I'll go into scoring in just a few minutes here, but depending on the setting that you're in, you would either choose, if you're not a small or a PCMH, you would either have to choose 4 medium-weighted activities or 2 high-weighted activities to get to the 40 points. Again, that's unless you're a small, where you'd already get the credit. You'd already get double credit, in which case you would have to do 1 medium, or 1 high, or 2 mediums.
And that small, again, is those that have clinicians, 15 or under clinicians.
That is correct.
Or under 15.
Yep, or are in a rural
area.
Yep, okay, exactly.
Thank you.
Okay, if a medical home satisfies this category, do you need to have the medical home in place the full year? And I believe the answer to that is no. I believe we found out that, I'll answer that question to the best of my ability that I believe I remember, was that we learned that as long as you were a medical home for the period of time for which you were attesting, that CMS would recognize that as being a medical home. And if that's different, I will clarify that. Reed, do you have anything?
I think that sounds about right. Like if you're certified during the measurement year, so let's say you're doing the full year participation, that would qualify you to get the points for that category. But if you're doing something shorter, like the partial year, as Candy was explaining in the Pick Your Pace of 90 to 364 days, I think that's where we have to do just a little checking to make sure that you have to be certified during that measurement period rather than just at some point during the calendar year if it doesn't happen to coincide with the dates that you're choosing for your measurement period.
And we will clarify that particular question. As you all know, and I'll point out in just a minute, we have regional office hours where we kind of open up the call for questions and so on. And so we'll put out a qualifying statement to that question at our March office hours.
You know, I think why don't we have you
keep going,
and then we are gonna monitor a couple of the questions. Just for everyone, if you would please put your questions into the chat rather than the Q&A. That way we have the ability for others who are participating today to also respond with maybe some best practice that they're doing. So if you would do that, and we'll let Candy go ahead, and then we'll stop maybe in a few minutes and ask some more questions.
Yep. I actually think we'll probably have a pretty good opportunity to answer most of the questions. But I think you're right. We should keep going with this for now. So in order to attest for, next slide, please. Thank you. In order to attest to an activity, you must meet all the requirements of the activity. Although you will notice that in some of the activity, it offers you several options for actually meeting the requirement of the activity. So pay attention when you're choosing an activity in that middle column where it does that thorough description, if it says and or if it says or, so that you understand that what it is exactly you'll have to do to meet the activity's requirements. Most of the activities, you would need to perform the activities for a minimum of 90 days. There are a few activities that require that you actually do the activity for 6 months, so you'll just want to pay attention to that. For this category, you must perform a selected activity for a minimum of 90 days to receive credit, and you will do so by designating a yes response on the improvement activities inventory when it is released. And in group reporting, this is a really important one. If you're reporting as a group, if one clinician performs the activity for at least 90 days, the whole group gets credit for the activity. So CMS will be studying the improvement activities category, as it is a new category, with a variety of stakeholders that they will elicit participation from. They plan to get a group together, hold monthly focus groups and stakeholder groups who will participate in studying this category, and the people who are submitting in this stakeholder group will be asked to submit baseline and quarterly data to help CMS analyze this category during the 2017 transition year. As they study this category, CMS is putting together a formalized process for adding new activities. The future focus will continue to be on participating with a qualified clinical data registry, as I already mentioned, and on advancing health IT.
Candy, if I may interject there, I just got off a webinar with CMS, and they were talking about the submission of new improvement activities and quality measures, and they do have a process in place now where you can submit those. However, the deadlines are coming up very quickly. For example, end of February for improvement activities that would be considered for the 2018 measurement period, and this webinar will be posted on the QPP homepage, and I'm sure, Candy, at the end we have a link or a reference to that.
Yep, we do. Thanks, Reed. Appreciate that. So now we're going to review how improvement activity scoring relates to the overall QPP scoring methodology. As mentioned previously, here are how the categories are being weighted for the 2017 transition year. MIPS clinicians will receive a point score that ranges from 0 to 100 points. And although this isn't the exact calculation because it's pretty complex, to simplify scoring, you would be eligible for 60 points, up to 60 points in the quality category, up to 15 points in the improvement activities category, up to 25 points in the advancing care information category, unless you were eligible for the exclusion, in which case your ACI score would be re-weighted to quality to be 85%. Or up to 85 points in quality if it was reweighted. And this is a visual of how the points you earn will impact your payment adjustments going forward. The categories technically go, for example, from 3.1 to 69, but for simplification, we've just put the points into these categories. Also, as a reminder, the performance period for the QPP is 2 years behind the payment period. So what you do in 2017 will impact your payments for 2019. So as you can see, if you do nothing and don't even do the test pace category, you will receive a negative payment adjustment of -4%. 3 points is all you need to receive a neutral payment adjustment. And if you're satisfied with that in the test period, or if you've really been struggling and you just need a year to get your workflows working better and to just dig into some more detail, 3 points is very easy to achieve, and that might be just where you're satisfied with being for 2017. On the other hand, if you're doing pretty well, you could score from 4 to 69 points. You would be eligible for a positive payment adjustment, and the higher up you get towards the 69, the more positive payment adjustment you would be eligible for. And of course, there would be no negative payment adjustment. But if you scored over 70 points, in addition to getting a positive payment adjustment, you would also be eligible for what's called the Exceptional Performance Bonus for the next 5 years, which is $500 million that's been set aside to share amongst those providers who are in the above 70 points category. And we have a tool coming out in the next couple of months that actually is a calculator. We're calling it our MIPS incentive calculator, and we're in the process of vetting it right now with some clients. But it's actually going to be a tool that you're going to be able to use in real time in 2017 to both get a baseline score based on your 2016 performance and the improvement activities categories that you would choose for this year, as well as to be a real-time calculator, if you will, so that if you wanted to put in your numerators and denominators for all of the categories going forward, either, say, on a monthly or quarterly basis, you will be able to know what your score will be. And so you'll have a pretty good idea of where you're performing well and where you might need to kick some extra effort into. So how do you get to 3 points? It's pretty simple. For those of you that have been attesting to meaningful use, there's actually 4 base measures in the 2014 cert. If you're using a 2015 cert, there's 5 base measures. So you would have to report all of those base measures, and then you would get beyond 3 points. You report quality measures, so if you reported one measure, if you were an individual, if you were a group that was using the CMS web interface, you would, there are 15 measures that are required in that web interface, or you would report one or two activities, or be a PCMH or a medical home model. And so if you're over 15, you would do 2 medium or 1 high, or 1 medium or 1 high in a small, rural, or non-patient facing. So as you can see, it's pretty easy to get to 3 points.
So Candy, would you like to take a few questions, or do you want to keep on going and then take more as we get to the end?
Let's take a couple of questions right now.
Okay. So one was, what are the requirements for a single provider who's not in a group?
I'm going to talk, next I was going to talk about eligibility for a single provider. So it will depend on what your Medicare Part B revenue is and how many Medicare patients you see. And so if you meet the threshold that I'm going to talk about in just a minute, you would, you're required to do everything that anyone else is as an individual for, because you would be a MIPS eligible clinician.
Okay. And we've got a couple of other questions that came in chat that we're also talking about eligibility, so I'm going to hold on those.
Okay.
But another question about the point part of it was talking, so you cannot do a combination of the medium and high to equal the 40 points.
Oh, no, absolutely. You should do a combination of the medium to a high. It's just that if you were a less than 15 or in a small, if you chose 1 high, you would automatically get your 40 points. So you're going to look at what setting you're in, and then you're going to determine, do you automatically get credit already? And if so, how much credit are you getting? And then how much more do you need to get to that 40 points? And so then you'll choose whatever combination works best for your clinic in order to get to that 40 points.
Okay. And a couple more that I think I'm going to hold off on until you get past the part about who qualifies, because there's a couple more detailed ones that are asking some questions in there. So
okay.
I'll let you go ahead and then we'll come back to the questions.
And I'm seeing a question in chat that I don't know the answer to. Do certified healthcare homes who automatically get the 40 points also qualify for the 10% bonus? I'm not.
That's a good question.
That's a very good question.
Because they're deeming you to be doing enough improvement activities that are already contained in that category, but you're not explicitly attesting to certain activities. You're just getting full credit for the category.
And if they're using CERT, would they get the bonus? We'll have to find the answer out to that one. That's a very good question. So we'll get the answer to that question. Okay, so now we're going to just quickly review eligibility requirements. So who's eligible for MIPS? So first of all, the people who are eligible, the clinicians who are eligible for MIPS have gone down to 5 categories of providers. So a physician, a physician's assistant, nurse practitioner, clinical nurse specialist, and certified registered nurse anesthetist are all the eligible clinicians in MIPS for the next 2 years. We are told, or we read in final rule that as we get to 2019, CMS has the authority to add in the other disciplines that they have added in previously, but at least for the next couple of years, those other disciplines get a little bit of a break.
And Candy, may I also add to that beyond the physicians, those other ones you mentioned there, the certified registered nurse anesthetists, the other ones as well, it's optional for you to report. So you don't have to, and then they would allow you to report if you wanted to and get credit.
For ACI.
For ACI.
Yeah, only for ACI. So for those others that you haven't been able to report to meaningful use in the past, or so in the advancing care information category, as was mentioned on the last webinar, those disciplines have the opportunity to decide not to attest for this year, in which case their ACI category will get rescored and reweighted to the quality.
That's right.
Okay. All right, so who's excluded from MIPS? So if you're newly enrolled in Medicare, so for the first time during the performance year, you're exempt until the following performance year. If you are below the low volume threshold, so for that clinician who asked about being a single individual provider, if you have charges, Medicare Part B charges that are equal to or less than $30,000 a year, or you see 100 or fewer Medicare Part B patients in a year, you are excluded or exempt from MIPS. You do not need to report and attest. And then also if you're significantly participating in an advanced APM, so that means that you're receiving 25% of your Medicare payments, or you see 20% of your Medicare patients through an advanced APM, you are exempt from MIPS and actually also qualify for an automatic 5% bonus. So conversely, who's eligible for MIPS? You're an eligible clinician, so you're one of those 5 disciplines, and you see more than 100 Medicare patients, and you bill more than $30,000 to Medicare Part B physician fee schedule. And the evaluation period for that was 9/1/15 through 8/31/16. So for claims who were submitted by November 4th, 2016. And so we kind of get this question on and off. If I'm a critical access or I'm a rural health clinic, am I exempt? And the answer is always going to be it's about how you bill. If you bill method 2, you're going to be eligible for MIPS. So how do clinicians participate in MIPS? Either as an individual under an NPI and TIN combination where they reassign their benefits, or as a group, 2 or more eligible clinicians or NPIs who have reassigned their billing rights to a single TIN, and as a MIPS APM entity. So just a couple of important timelines and important dates that you should continue to pay attention to. Just as a reminder, remember the end of February and or in March are your attesting and reporting periods for PQRS and meaningful use. If you have, depending on the reporting strategy that you are using, that 2017 is a transition year. So that began January 1st, 2017. And we're in the Pick Your Pace options in 2017. And your option to start as late as October 2nd, 2017 to do a 90-day reporting period. So if you're going to do 90 days, you have to start by October 17th, or by October 2nd, excuse me. You may use 2014 or 2015 cert in 2017, but it's our understanding that most clinicians don't, or most vendors don't have 2015 cert available yet, but you have the option of using one or both. And 2014 cert is acceptable for 2017, but we are told to be ready for your 2015 cert for January 1st, 2018, which I'm sure the vendors are very aware of. So again, Pick Your Pace options in 2017. The first one really isn't an option. Well, it is an option. Someone said to me last week, is MIPS, is it optional? And so the answer is, well, yes, it's optional in that if you don't do it, you're going to have a negative 4% payment adjustment to your Medicare Part B revenue. So we don't recommend that. And we do believe that CMS has done a nice job of setting clinicians up for success in 2017. So again, you can do a test option, which means that you would do something. So you would report on one quality measure or one activity for the period of time in which the specification lists the time frequency. You could do partial, in which you'd submit 90 days of 2017 data, in which case you'd still earn that neutral or small payment adjustment, or you can do full if you feel like you want to shoot for doing it all, to be eligible for the most points in the scoring system. And of course, the other option is to participate as a qualified participant in an advanced APM. But because the percentage is so low for 2017, we're focusing most of our energy on MIPS-eligible clinicians for 2017. So again, this is just, your measurement payment adjustment cycle for 2017 is the performance year. There will be feedback available from CMS. But as we know, the feedback has not been as quick to come as we would probably like to see it. But again, as I said, we're coming out with our incentive calculator tool in the next couple of months. As I know that other Quinn QIOs also are working on similar things. And so we're really excited to be able to put that in your hands and have you have that as a really tangible resource for 2017 and moving forward. So the next few slides are just resources and tools. For the LS Quinn's role in QPP, our role is primarily around education and technical assistance. It's also to get as many clinicians and physicians engaged in understanding QPP in your role in QPP and how you can be as successful as possible in it, as well as beneficiary engagement. And so we have a webinar series going on, as you know. Our next webinar will be March 29th, which will be the quality component of MIPS. And then as of 4/20, we're going to focus solely on calculating a MIPS score. And we're really hoping to have our MIPS calculator out for that April 20th webinar. We also have office hours as a technical assistance forum, and those are the second Thursday of each month. They are held 11:30 to 12:30 Central Standard Time, 12:30 to 1:30 Eastern Time, and our next call is scheduled for March 9th, 2017.
Would you like to go through a few more questions?
Yep, hang on just one second.
Sure.
So this is the QPP Help Desk number and the QPP mail. And so they will take calls or they will answer email if you want to go directly to CMS to get your questions answered. And then the next set of resources are just some resources that if you want to dig deeper into the QPP program, we've listed some additional resources for you. So if you go to, keep going to slide 43. You can see that here are the contacts for each of the LS Quins. All right, Jane, so let's see if we can answer some more questions.
I think some of these you might have answered about the eligibility when we were going through it, but I'm going to go through them and they might just be a quick answer and maybe a little bit more clarification. For groups of fewer than 15 providers, does that mean fewer than 15 providers that meet the eligibility guidelines for MIPS, i.e. more than 100 Medicare patients visits, more than the 30,000 billed to Medicare?
So as far as improvement activities is concerned, Candy walked us through the higher scoring of having just one high improvement activity or two mediums. But as far as participation goes, there really isn't anything different when it comes to that eligibility. Let's say you had a large group practice of 70 clinicians. There really isn't anything that differentiates between that 30,000 threshold and 100 patients as far as individual participation in the program. When we get into groups, and you look at it on a group basis, that's kind of an interesting one because that threshold applies then to the group, not to the individual. Are we capturing the essence of that question, Jane, or?
I think so, but I think that there's another question in that I'm not sure that we'll be able to answer yet today, and that is because I thought that CMS took, you could look at their eligibility either as a group or as an individual, and I think the question is if you had some people in the 15, is it the 15 by eligibility, by that 30,000 or the 100 visits? Is that what qualifies them as less than 15? And I'm not 100% sure what actually qualifies an entity as less than 15.
Right, so is CMS making the determination that you are a practice? So
we'll have to get an answer to that.
Because we're looking at the 10 level, when we're doing groups, that CMS might look at that also at the 10 level, but we'll have to follow up.
And so we'll follow up with that in the office hours. We'll do some follow-up to this webinar in that March office hours. So
it's an interesting question, too, just to add to that, because there is fluctuation in provider numbers.
Right.
And when is that determination made?
Right.
You know, you may be at 15, but you have a couple folks move on, or you're below that and you have a couple providers join your practice at some point. So we've got a few little nuances to dig into.
Yeah.
And there was another one that kind of maybe piggybacked on that a little bit. Would ECs attest individually or all together if less than 15 providers? We have always attested individually. Also, it is a specialty clinic, so how could we streamline the IA?
Yeah, I mean, that's a choice that you'll continue to have, you know, whether or not you'll attest as individuals or groups. And you know, as we get more savvy at doing this, you know, I think we'll be able to be smart enough to say, oh, well, you know, this is how we do as individuals. So, for example, once you get your MIPS calculator, for example, you're able to actually do sort of a baseline score. You'll be able to score all of your individuals. You then would have the ability to aggregate the group based on the scores to know if you would be better off, if your group would be better off reporting as a group as reporting as individuals. So,
exactly. I think you have to run some what-if scenarios
yep.
and see how you do individually versus a group. And we also have that interesting aspect that Candy mentioned about one group member doing the improvement activity that would kind of grandfather the entire group in. So you
right.
want to look at that.
So that might be the advantage of doing group reporting in that scenario. So absolutely.
So getting a little bit more detail on the IA requirements, the question was for the improvement activity regarding provide 24-hour access to eligible clinicians. If we have a physician covering our ER 24/7, does that cover this measure? The physician is always on site. Do we have a detail on that?
I think some of these, like Candy described, these are broadly worded in nature, and sometimes we do need to go to CMS for some interpretation for a specific scenario, and I think this might be one of those situations.
Absolutely. So I would either encourage you to go to that QPP portal and ask them that question because they'll be able to answer it just right out of the gate, or certainly check in with one of your LS Quinn contacts and we can see. So that's a great question. You know, that's the thing that we don't know in the improvement activities category. You know, so for example, there's an activity about providing timely access and follow-up to Medicaid clients. Well, what does that mean? You know, yes, of course we do it. Okay, well, how do you prove that? You know, so we don't know that yet about some of those details of those activities. We'll learn them, I'm sure, as we continue to get smarter during this year. But again, we don't know the specifics of how you do that. And I see a related question that says what will be needed to be submitted as evidence for IA. And I'm thinking in the first year that it's just going to be you're going to attest, you're going to say yes to the categories that you're actually attesting to. And I believe, in my mind, we don't know this for sure yet, but it would seem to me that the audit eventually, when they start doing audits on improvement activities, so I would set yourself up to be successful in your first year, you know, however it is determined that you are actually meeting the requirements of that activity, if it's whether it's doing a screenshot or whatever, just similarly to what you've done in meaningful use to prepare for an audit, you're going to want to set yourself up to be successful in that same way, whether it's, you know, you need the leadership in your organization to say something. We don't know. Depending on how the details are of the requirements, we'll help you know what kinds of things you should do and keep track of for an audit.
I did contact CMS Help Desk about the audits in general for QPP, and they don't have any specific guidance on that yet. So that's in development, but like Candy said, we were kind of used to in meaningful use doing screenshots for objectives and measures. I would continue that, like she said, and then going forward, we kind of suggest what's the spirit of this, what would be prudent, maintain some sort of evidence,
right.
But we don't know the specifics quite yet.
Yep.
So another question was about, and this is a little bit more Minnesota-centric, but it's asking for Minnesota Community Measurement Participation qualify as participation in Bridges to Excellence. don't exactly know what the essence of that question is.
Yeah, so Bridges to Excellence. So that's a great question for Minnesota, and I don't know the answer to that yet, but I know there is an activity about participating in Bridges to Excellence. So we'll have to do some follow-up in Minnesota to Minnesota Community Measurement to see if that is a qualifier in the Bridges to Excellence program.
And there's a question about, is there a list somewhere of the CEHRT reportable improvement activities?
Yep.
On the QPP website?
On slide, just hang on a second, I'll tell you, there was an earlier slide that I gave you that talked about the bonus, the 10% bonus. And in that slide, there was a URL on the bottom of that link, and that URL actually took you to the Advancing Care Information fact sheet, and then start on page 9, and then that takes you to those 18 activities that are search activities. So I'm kind of looking through my paper as I'm going along here. But
so you look for that basically, if you go to the CMS website, and we've given that out, it's the qpp.cms.gov, and you'll see the upper, right-hand corner, education, and you'll scroll down to the ACI activity sheet, which is about, I think, halfway or two-thirds the way down the page. And in that, like on Candy's slide here, on pages 9 to 19, I believe, it lists out each of those individual activities. So that's in the slide deck, and Jane, we did send that out in advance, I believe.
Actually, there was a link.
There's a link.
Right there. On slide 14, you'll see that ACI fact sheet list, and the URL down there will take you right to the bonus.
I'm going to pop ahead. We're actually getting wonderful questions. Thank you very much. I don't know if we'll get to all of these, but do know that we're going to cover some of these also when we do our office hours on the 9th. But one of the questions came from a participant who says, when or how can I register NPs and PAs and CNPs and et cetera and so forth for MIPS? Currently, the EHR website will only register these mid-levels for Medicaid.
We don't have a registration process. This is something that's different. Under the Meaningful Use Program, you had to proactively go into the website and register. Now, under the MIPS program, CMS is making that determination. And Candy, I don't know if you recall what the date was, but they were going to send out some information about eligible clinicians. Have to be careful with my terminology there, but that would go out. So you don't have to register in advance of participating in the program.
Right, and so as Reed mentioned, CMS has told us that they will be posting sometime soon a list by eligible clinicians as to whether or not you're eligible to report MIPS. So there will be a way to kind of double check that as well.
You know, another question that talks about the rural component, and I think it's that less than 15, the questioner wants to know how do we know if we are considered to be in a rural or health professional shortage area, and who determines this, and where can I find that the regulation?
Yeah, and that's something that we are going to research, and we will have available to answer at our office hours. And it probably makes sense for us to post that on our LS Quinn website as well. I haven't talked to my regional partners yet about this, but it makes sense that as we have these questions going forward, that we may want to research them and post them there as well. So we'll get that figured out.
Okay. We've got, let's see. Oh, I've got another question. Sorry. Clinicians and PPMH models who get full credit can still report their activities and therefore receive bonus points for those activities?
No. So that's a great question. You certainly can attest to more than 4 activities, but the most points that you're able to get out of the improvement activity category is 40, and then and then you're also then eligible for the bonus the 10% bonus in the ACI category if you use CERT. But that is, and then even with the bonuses, it's capped out at a certain level. So you still want to go for as many points as you possibly can to try to get into that 70 and above if that's possible. But no, you don't get extra credit, if you will, for doing additional activities that score you over 40.
So if we have providers that we will also attest Medicaid meaningful use, do we need to have the same reporting dates for MU and MIPS regardless of whether it is 90 days or a year?
Reed, can you answer that question?
Can you restate that again? It was
if we have providers that we will also attest to Medicaid meaningful use, do we need to have the same reporting dates for both the meaningful use and for the MIPS?
No, you don't, because the programs are really considered to be fully independent of each other at this point.
Great. Oh, what number do I call for office hours on 3-9? So we'll have
you have to register.
Yep, you have to register for office hours.
And once you register, you will receive a registration confirmation.
And an agenda.
Yep, and a link in that will give you the link to the, because we do this semi-webinar-ish. So anyway, we'll give you a link to that and then call-in information. Is there a benefit to group reporting versus individual reporting?
You know, and that's a very clinic by clinic specific answer. And so, as I said, once you get your, once you have the MIPS calculator in hand and you can do some scoring for your individuals, then you can aggregate some of your scoring for group to see if scoring-wise that makes a difference. It's really a very individualized, if you report as a group, you have to report the same measures and the same activities across all 4 categories. So that's something to consider. Otherwise, as individuals, you can just report individually. So different considerations that you have to think about for that.
Well, this is an interesting one with regard to penalties. Is the 4% penalty for not participating in addition to other penalties the practice may already be experiencing, i.e. CQRS or MU, or will those penalties be replaced by the 4% penalty?
That's a great question. So we start over in 2017 for the payment year of 2019. So you could be experiencing negative payment adjustment in 2017 for performance year 2015, but for 2017 we start over, and so if you do nothing in 2017, your total negative payment adjustment will be -4%.
And maybe just to add to that, there's a progression of payment adjustments. So currently in 2017, that 4% would be applied, as Candy mentioned, in 2019. In 2020, that goes up to 5%, 2021, up to 7%,
good point.
And then 2022, 9%. So currently, if you had participated back in 2015, or let's see, 2016, and you're seeing that payment adjustment, that could be as high as, I think, a little bit over 10% because they're stacked. Then it's going to snap back a bit to 4%, but then it will progressively increase over the years, up close to that current 10% roughly stacked penalty.
The other thing to think about is, in 2017, of course, the amount of positive payment adjustment that's a budget neutral payment adjustment, that will be eligible will be relatively small because CMS is expecting so many people to be successful. But beginning 2018, we'll be out of a transition year, and there won't be nearly as many, in my mind, there won't be quite as many successful reporters necessarily for 2018, which might make more money available for the positive payment adjustment.
And I think that's especially true because you consider not a lot of EHR vendors have gone through the 2015 certification process, and this is considered to be that transition year. We know that January 1st, 2018 is that new full-year measurement period, and there may be a number of folks who haven't gone through the upgrade process to their 2015 cert and can't do a full year of reporting. So we have an interesting scenario next year about who can actually fully participate for a full year.
Okay, and I think we're probably going to have to bring it to an end because we're just right at the bottom of the half hour right now. So I want to thank Candy. I know that Lisa Gall, another one of our SMEs, has been on the line and answering some questions. So thank you for a great presentation. At the end of the webinar, you are going to be popped into a link for a short evaluation. Please complete that and answer the questions and especially ideas on what you might want us to cover in the future. And also, once you complete that evaluation, there will be a certificate of participation that you can use or utilize for continuing education credits within your professional arena. This presentation is going to be recorded. It will be posted to the LS Quinn website. It takes approximately 2 weeks. And please join us when we do our office hours on March 9th, and you will also find that registration link on the LS Quinn website. Thank you and have a wonderful day.